I have been developing many non-contrast techniques, so that's why these topics come to me, but I am not the professional people for the pathway of the gadolinium retention. Maybe we can sort it out together, but these are the debating issues in many conferences. Okay. So my content gonna be gadolinium retention, why it's interested, and also gadolinium deposition disease, how gadolinium get into the tissue, how much is enough, and total cost, from the non-contrast perspective, how much is the real cost of the gadolinium examination, and current non-contrast SMRA, which has been established, and most of the vendor has, and something that can rely, and the future direction. Okay, so the first, gadolinium retention, as the chairman just mentioned, that gadolinium deposition and these things happen, and toxicology of gadolinium was started from the nephrogenic systemic fibrosis. But after those are taken care by checking the kidney level. So, but about 2014, the gadolinium deposition in brain, bone, and skin has been notified, and ongoing research for the pathway of these issues. And people say that there is no immediate disease, but I check on PubMed, and there are some reported papers, so I'm going to just introduce those and has on the ongoing research of the pathway of gadolinium retention and toxicology. So gadolinium deposition disease, this number 9 paper describes many things, but mostly pain, skin changes, MSK malformation, and central nervous system findings, and persistent disease. This paper describes that there is acute, mean within 3 months, and chronic, mean after 3 months, and single dose injection and versus the multiple injection. Of course, with the multiple injection, you have a more incidence. And this is the first one is the site of pain. It describes many central pain, peripheral pain, headache, and skin change. And this is more noticeable with a multiple injection. Okay, the other one is MSK modifications, and this shows again the single dose is less. I'm sorry. Single dose is less compared to the multiple dose, and more chronic has been reported, and I don't know how many people has been injected yourself. Anyone have a multiple injection? No? Oh, many? How about the people who doesn't have any injection? No contrast. So those people who doesn't inject, would you like to inject yourself? For if you have an alternative way, such as by non-contrast, would you like to go on the non-contrast? If though that the contrast examination is like 10 minutes, but the preparation something, it would take about 30 minutes. And the non-contrast may take 20 to 30 minutes. Is that possible? Those people who does not have the contrast agent, anyone want to go for non-contrast? Quite many. So, Dr. Dweck, would you like to go for non-contrast?
Yes.
Okay. Okay. So these are the diseases they reported. And in ISMRM, I have heard from Dr. Taoka and Dr. Naganawa, they were finding the pathway of gadolinium retention. Why is gadolinium getting to even intact BBB or kidney function is normal? So their proposal is that from choroid plexus or canal nerve ending and get into the cerebrospinal fluid and perivascular space and interstitial tissue and perivascular space and go into the central lymphatic system. And this is quite interesting because they use the 3D FLAIR technique to wait for a while to check that the gadolinium retention. And they found that these are highlighted area, I think after 4 hours, and this side is the female on 49 years old, they have some retention. The young people, 17 years old, does not show any retention. They have an age correlation, age difference, who doesn't have any gadolinium in the brain, or maybe we don't see it. too micro, we don't see it, but they study the ages. Here is another graph showing here's 20 to 70 years old. Gadolinium number of slices, they can see the gadolinium retention is more in age around 40. So those people who are younger than 40, maybe you can inject, you don't have a retention. This one shows, but, But people more than 40, we don't know why, but some kind of gadolinium has changed the form and get into what was the previous paper? Previous one. They said it's in the cortical veins. So this is the fact they reported for the people who had the 3D FLAIR to see more of the retention has been found in the elder people. Okay, this was my original intention of developing non-contrast was the Japanese doctor wanted to do, since MR is non-invasive, no radiation, so why not be able to do with the non-contrast? That was a long time ago, 1995 or 96. And then I didn't know the real reason. Maybe intrinsically they don't want to inject, but also the cost. And each country have a different cost. And that time in Japan, the contrast agent was $200 per bottle, 20 ml, and MR examination was like $150. I think now it's about $130, doctor. Yes. So the cost of the gado was more than the MR examination. I don't think any countries are like that, but the cost is the matter in Japan. And also the time. There's some place, in Japan, most of the time the doctor have to go there to inject and observe. So time to get the root to the vein, and also attending the physician, and also now you have to check the kidney function. So, and now I think in US there are many phone calls that I heard from patients why they have to do inject, and you have to consult for gadolinium injection examination time. So those are the time costs for the gadolinium injection. And now, at least all vendor has the renal MRA. Oops, sorry, it's working. Okay, MRA. This is non-contrast. At 3T, we acquire coronal placing the tag post in the abdomen, just above the kidney, and you'll be able to observe the inflow effect of the aorta getting to the kidney, be able to depict something like this. And this is the coronal scan that this was found out the normal patient that has 4 renal arteries, and 2 on the left, or 2 on the right, and 4 on the left. So these are done in coronal scan. You can do it in both ways, axial or coronal, which can cover more. Of course, the balance sequence require good shimming to make it uniform. And here's the runoff. This one was acquired by fresh blood imaging. And these are the patient. I mean, the images for the ASO patient who has the occlusion here, showing CT and the similar delineation of the non-contrast. And this was obtained from Dr. Nakamura from Japan. So these are the available technique, and I think we have to tweak and get used to it, then you'll be able to do it. I think first time for the contrast agent, you have had many mistakes too, and you found the timing. So I think it's a time that we have to do. And there are many other non-contrast techniques, such as the quiz by Bob Edelman and flow sensitized dephasing technique, and now velocity selective techniques are there. So we are going to establish more. So, and hope that next year more non-contrast technique can be shown here in this conference, and maybe venogram. That's maybe the key. Thank you so much.